patient. When a patient presents with pain around the forefoot and we're suspecting a stress fracture, palpation is really important. So we have our tibial sesamoid, which is on the medial side of the foot, and our fibular sesamoid, which is on the lateral aspect of the sub-first metatarsal phalangeal joint. Palpation is really important. Sometimes when you're palpating, you may see some oedema present off the side of the toe. So I'm often inspecting for some swelling in the area. Again, feeling for some heat, comparing left and right. Typically, patients will also have pain with hopping and so forth. Some differential diagnoses would again be some joint capsule injury or plantar plate injury. So we can do that vertical stress test where we're stabilising the proximal phalanx and we're dorsiflexing it on the first metatarsal. If there's disruption to the plantar plate, you'll see some subluxation of that joint. What we can also look for here is injury to the flexor tendon. So I'll ask the patient to gently flex their toe into my thumb and I'll palpate through the medial arch of the foot. We know that the sesamoids are in the flexor hallucis brevis, muscle and tendon. And as we approach the sesamoids, we can often distinguish between the tendon and the bones themselves. So I find this muscle test is a great way to distinguish between tendinopathy and sesamoid pain.
Sesamoid fracture, have you seen many of those? Or?
I've had 2 of them myself actually. Oh. So
you're really banged up.
I'm pretty banged up. I've had a fair share of injuries. So I've mainly got it not through running per se, it was football, and it's not uncommon in football because of the football stud being located there. In saying that, I work with an AFL club, as you know, and I haven't seen a sesamoid fracture at the club. We've had a few players come in who had them when they were younger footballers. So there actually isn't a whole lot of data on when they're likely to occur, but anecdotally, I seem to have seen them in younger athletes who are really ramping up their running. So, late teens, maybe early 20s. Yeah. They don't heal very well according to textbooks and so forth. And the way I managed mine was definitely not textbook. It was really just using pain as a guide. I, at the time, was recommended that I'd need to have surgery or go into a cast. I didn't like either of those options. So I just kept playing basketball, and so I basically had it during football, retired from football, went into basketball and just offloaded it and managed the pain, and eventually the pain disappeared. Yeah. And interestingly, I had a repeat x-ray for a different injury and they had healed. Yeah. So although the textbooks would suggest that they won't heal, on one case study where they did, I wouldn't recommend you try that with your patients though. I would, if I had my time again, I probably would have put myself in a cam boot, 6 to 8 weeks, and would expect a pretty good result doing it that way.
Yeah.
Unload it in a cam boot for 4 to 6 weeks and it'll settle down. So two very different scenarios. Pure and all the Another high-risk fracture that we see around the midfoot is the navicular fracture, and the way that we can locate the navicular most easily is to find the tuberosity on the medial side of the foot. Now, on some runners it's quite prominent and easy to find. In this person here, it's not as obvious. So we locate the tuberosity, we move dorsally, and it's around this region just in front of the ankle where patients often present with pain if they have a navicular stress fracture. It's known as the end spot. It's typically in the central aspect of the navicular, not the medial or the lateral, and we get pain with direct compression. It can be confused with anterior impingement syndrome or impingement of the ankle, so it can be difficult to diagnose. It often gets misdiagnosed, and for that reason, it often has a delayed diagnosis.
Any tips there with the navicular?
Not really. The only tip I would suggest is anyone who's presenting with medial ankle pain, always have that in the back of your mind. I've seen a few navicular fractures that have actually coexisted with an anterior impingement syndrome as well. And there was a time there where if you went in for surgical repair of a navicular, they're also scoping the front of the ankle because a reduced ankle dorsiflexion was thought to contribute to the load on the navicular joint, whether it was simply because you don't have enough motion at the ankle, it's just simply being demanded of the next joint down, and that puts stress on the navicular. It might have been the school of thought, but they can go hand in hand. There was some early work published by Peter Bruckner that also found that a lack of ankle dorsiflexion is a risk factor for navicular stress fractures. So if someone's presenting with anterior impingement syndrome, or potentially in the back of your mind you're thinking navicular, I treat it like an anterior impingement syndrome early, but be very alert that it might not be if it doesn't clear with, say, ankle mobilisation, for example, or maybe a heel lift to unjam the front of the ankle. I have an interesting story to tell you about navicular fracture. I think it's interesting. We had a footballer, so not a runner, a footballer who presented with what looked like anterior impingement syndrome, and went off for a scan, and there was some bonioedema in the navicular and also what appeared to be a fracture line. Went for a CT scan, it came back clear. So this is unusual. We'd already booked him in for surgery or surgical opinion. Gone back and looked at that MRI and observed it wasn't actually a fracture. It just happened to be a nutrient artery running through the navicular that appeared to be a fracture. It just so happened that there was some bone stress in the background anyway. There was actually a stress reaction. So the management went from, he's probably going to have surgery and ankle scope and all the rest, to actually no, it's just bone stress, unload it in a cam boot for 4 to 6 weeks and it'll settle down. So two very different scenarios, purely based on, I guess, interpretation of some imaging, and knowing that sometimes you can get a stress reaction occurring around a nutrient artery in a bone, or just there is those little red herrings every now and then.
Yeah, and clinically, did you say they were presenting like the history was making you think navicular, or you definitely thought that this is ankle issue? Or?
No, it did present, well, it presented as ankle, but often that impingement at the ankle can often be a navicular fracture. The thing with navicular fractures is they're not overly painful. So even though they might be considered a high risk fracture, and no one wants a navicular fracture because they've got a bad reputation, it's not because they're painful. That's why they have this delayed diagnosis, and that's why a lot of people turn up and it's a really deep fracture, and that's why often they need surgery. So you really want to pounce on them early if you can, so that if there is a breach of the cortex, it's not extending through the body of the navicular, and there's minimal risk of it breaking down over time. So early diagnosis is key.
Yeah, it makes sense.
If someone is presenting with dorsal medial foot pain, it's important to eliminate a tibialis anterior tendinopathy, an extensor lucis longus tendinopathy, or even a extensor digitorum longus tendinopathy. So muscle testing can be quite useful in this setting. So here I'm going to stabilise a rear foot. I'll apply pressure on the forefoot and I'll ask the patient to pull their foot back towards them. And as they're dorsiflexing, I can see the tibialis anterior is quite prominent. Here's an opportunity to palpate that tendon and see if it can reproduce the patient's symptoms. If they had a navicular fracture, this should not hurt them. However, if you can reproduce pain, then I'm starting to think it's more of a tendinopathy. The same can be said about the EHL. So I'll have the patient dorsiflex their hallux. Here we can see the tendon's quite prominent. I'll use my thumb to palpate along that tendon, trying to avoid compression of the navicular, and we'll repeat the same with the extensor digitorum longus, which is a slightly lateral, so it's less likely to be the cause of dorsal medial midfoot pain. When considering a calcaneal stress fracture, it's important to also consider the structures posterior to the ankle as a potential diagnosis. So we have our mid-portion Achilles tendon, which we can palpate through that region. What you're more likely to consider if your patient has a calcaneal fracture, however, is insertional Achilles tendinopathy. So we'd expect to be pain with palpation on the posterior heel. Posterior ankle impingement may also be a potential diagnosis for posterior pain, which we can reproduce with plantar flexion of the ankle. Sometimes it needs to be quite forceful to reproduce that. But again, with a calcaneal fracture, you'd expect symptoms to be reproduced with lateral and medial compression. So maybe two other heel diagnoses to consider would be a fat pad contusion, which is bruising, but it's more on the plantar surface of the heel, and there's normally a history of impact, but not always. particularly if you're doing some trail running, you might get a rock that shoots up through the bottom of your foot, and that might happen so often you don't really notice it on that run, but it can lead to bruising, so that's something worth considering. And then plantar fasciitis, which we haven't really talked about today, or plantar fasciopathy, whichever term you prefer, but again, that's typically plantar pain. But when I am treating someone with plantar fasciitis, I tend to squeeze the calcaneus out of habit just to eliminate the risk of the diagnosis being a calcaneal fracture.
Yeah, and we could have a whole nother masterclass on plantar fascia and Achilles,
Yes,
and
certainly could.
which I don't think we'll dive too much into today. But
We'll spare it for someone else to talk about. But something that can be really simple and cheap to treat a calcaneal stress fracture is something like this, a little silicone heel cup. This is a tiny one for a young person, but that can just be enough to take the edge off and allow people to walk around comfortably, or even just a foam-based insole. It doesn't look like much on camera, but this material is called Poron. It definitely does reduce plantar pressures under the foot, and it comes in different thicknesses. So you can get it 3 mil, 4.5 mil, 6 mil, so you can build them up. It provides a lot of cushioning, and that can provide a lot of relief for someone who's experiencing heel pain, and something that you can use when they're returning to running.
Yeah, great tips.
Okay, so we briefly talked about imaging earlier, and here's a bit of a recap on if you are assessing somebody, you've done your muscle testing, you've looked at joint range of motion, and you're now thinking, look, it could well be a bone stress injury. We've got 3 main choices: X-ray, MRI, and CT scan. I've left bone scans out. I've got that little dot point at the bottom. They do exist. They're highly sensitive, but they're not very specific. And they're rarely used these days because of the high radiation that they emit, and because there's this improved access to MRI. So if we went back 10 years ago, they were being used a whole lot more. If we go back 20 years ago, they were used a lot because of that reason. But now there's really not much of a place for them with X-ray, MRI, and CT scan. So I guess as a clinician, if we're sending off for imaging, we've got some cost issues to think about. Now, X-ray is relatively the cheapest. You can actually bulk bill in Australia and not have to pay for X-ray at some places. So it's relatively low cost. MRI, I don't want to put a price on it because everyone will charge different, but you're probably in the vicinity of say $300 for an MRI. CT scans as well are relatively expensive compared to an X-ray. So as a clinician, I guess our first 2 options are either X-ray or MRI. We've got the cost factor to consider. What will it show? So the X-ray will show us chronic bone stress reaction if it's been there for a long time. So that's thickening of the cortex. Again, that's the most outer thickened layer of bone. It might be thickened if there's a stress reaction present, but it may not show. A stress fracture is likely to show at 2 to 3 weeks, and what we're going to see typically is a defect in the cortex. You might see what's called a bit of bony callus, which we'll see soon on some imaging. With MRI, you'll see some periosteal and bone marrow edema, and you'll see that really early on. If there's a fracture present, you'll see a fracture line. If there's a bone stress reaction, you'll see that bony edema but no fracture line. So that's the way that you would distinguish between the 2 on an MRI. And as I touched on earlier, the CT scan is an excellent way of visualising a fracture line. So if you needed more information, and that was going to change your management plan, that's when a CT scan would be quite useful. And again, they typically get used on navicular and 5th metatarsal fractures affecting the proximal diaphysis.
Yeah. And you mentioned in Australia we're pretty lucky with the healthcare system and being able to access a lot of these things. Advice, I guess, for people in countries that don't even have access to any of this,
Yeah, well, if you don't have any access to any of this, then you'll be basing your diagnosis on your clinical observation and skills. And I guess if you're dealing with what you would suspect to be a high risk stress fracture, you would assume it is that until proven otherwise, because you'd hate to, underdiagnose in that case. Now, we don't want to overdiagnose people, but you don't want to send someone out to run and they go from a stress reaction in the navicular and becomes a full-blown stress fracture, for example. Regarding the low-risk stress fractures, I'd be quite comfortable diagnosing a lot of those as clinically. out of habit, and because we have access to X-ray, you would throw that in the mix for that added information. But if you don't have access to X-ray or MRI, then I think you can quite confidently diagnose based on your clinical assessment.
Yeah.
Okay, so now we're going to look at some imaging for a few different fractures. We'll start with metatarsal fractures because they're by far the most common. And I think, having just discussed what we've talked about, it's important to have a logical sequence of imaging modalities. We're not going to send off for X-ray, MRI and CT scan because we can, or the patient can afford it. We're going to be logical, so we're not over-servicing people and over-diagnosing. So X-ray is often a good first step. Typically you would have a minimum of 2 projections, and you can see different things on different projections. So you might not see a fracture on one and you may the other. So I would typically order 3, but you best order 2, and it'd be best to order bilateral X-rays as well. So you have that control foot to look at, because again, we do get a lot of anatomical variation between people. And sometimes you might see something that's just an anatomical variation. It just so happens in the location of where their pain is, and it could throw you slightly. So it's always good to compare to the other side. What we're looking for here is the thickening of the cortex of the second metatarsal. You can sort of see that sort of extra white area. It's thickened, it's got some sclerosis, which means some extra bone has been laid down. Earlier on, I talked about targeted remodelling, and that's where we have the osteoclasts going into the fracture site, absorbing damaged bone, osteoblasts are applying new bone. When we see that sclerosis or that sort of callus forming, that's actually called modelling, not targeted remodelling. And that modelling is simply just a laying down of bone. So we have osteoblasts that are laying down a matrix to just help restabilise the fracture site. So it's good to sort of have a sense of the physiology behind what you're seeing there. We know that there are osteoblasts in the vicinity and they're trying to heal this fracture. So although you don't want to see a fracture and you don't want to see callus, the fact that you are seeing it would say that healing is starting to take place. A good thing about X-ray is it will tell us if there is displacement or not. So here we can see there is that bony callus, but there's no bony displacement. We don't see a full break and that metatarsal has slid off the fracture site, which I have seen before, definitely can happen if you have a full thickness fracture. If negative and you need to know, so the scan comes back negative, you need to know if there's a fracture present, then an MRI is an option for you. But the question I'd always ask yourself as a clinician is, will it change the management? So whether you find out if there's a fracture or not, will it change the management? If the answer is no, then I'd be comfortable not ordering that MRI. If the answer is yes, you know, someone's got that, I think I used the New York Marathon, we'll make it Boston this time, the Boston Marathon or the Melbourne Marathon in a few weeks, and they need to know, then the MRI is a good investment for that reason. Here we can see another metatarsal fracture. Here we're seeing potentially some periosteal bone formation, so some extra bone being formed on the outer surface. We can definitely see a fracture line, and you could argue whether there's some sclerosis there as well, some slight thickening of the cortex. But the most important one here is you can see a fracture line, and that would be enough as a clinician, physiotherapist, podiatrist, doctor, whoever, to say, well, there's a fracture, let's now treat it accordingly. So really, when you see a line, somehow that gives you comfort that there is, okay, there's a fracture, we have a diagnosis, and luckily in this case, it's a low risk one.
Yeah.
Now, I talked about a nutrient artery earlier, a nutrient vessel around the navicular, and it's not uncommon to see them around the mid-shaft of the metatarsal when you have an oblique projection. So that's where the X-ray is sort of coming down on a bit of an angle. So we've got that oblique projection, and we see this nutrient artery channel that may be visible. Now it's really easy to misdiagnose that as a fracture, particularly if they've got pain in that area. It's characteristic of metatarsals to see that. It is rare, but they do happen. So just be aware that they are there. Here we have a MRI. Okay, so the great thing about an MRI is they visualise fractures quite well. They light up. We can see it. It's really, it's almost drawing us in. The lights are on, and a fracture is home, unfortunately, for this person. So here we have a 13-year-old boy. It's worth noting that this is a male runner, because you can see some growth plates just distal to the metatarsal heads. They're not fractures, they're just growth plates that are still developing. So don't get them confused with a fracture. We can see that there is a periosteal reaction. So it's got that white lit up exterior or outer surface of the metatarsal, and we can see some oedema in the bone. In essence, that third metatarsal looks completely different to the fourth and fifth and the first and second, so it's really lit up there. Another, I guess this sort of falls in the stress fracture category, is a infraction of the second metatarsal head. This often gets called Freiberg's infraction. It's actually an avascular necrosis. And when I have seen this, it's often been in adolescent female runners. So we see this more in females. Typically see it around age 12, 13, 14, thereabouts. Can be quite painful. Again, there's no incident of injury that gets reported to you as a clinician. And where you'll see pain is right on that second metatarsal head. So I didn't show this in the videos, so I better demonstrate now. You'd get pain being produced right on that second metatarsal head. It'd be clear further back. It wouldn't be painful at proximal phalanx. And imaging is pretty obvious when you get it done. What you see is a flattening of that second metatarsal head. So the other metatarsals have got this sort of round sort of shape. That second metatarsal head's got this collapsed shape. Now, there's not much you can do for them apart from unload them. And we're going to look at that in our management section on different unloading strategies. The way that you would unload it would be like we unload a stress fracture, which we'll talk about soon. Yep. And almost time will help settle it down. So you're possibly looking at a 12-month window of some discomfort, unfortunately, for this particular person. Hopefully you can get there sooner with some offloading strategies. The risk is, if this person keeps playing through pain, that they can get some arthritic changes in that joint fairly early in life. Here we have a normal fifth metatarsal apophysis formation, and the reason why I've put this up is that is regularly confused for a fracture. Now, the difference being that this apophysis is longitudinal in its orientation, that's why I've pointed out, whereas a stress fracture will go across the metatarsal, transverse. So that's one way to distinguish between the two. Of course, you'd expect this to be occurring in a young adolescent. They still haven't fully matured, so we're probably talking around a 13, 14, 15-year-old here, potentially. So it's always important to keep that in mind. And I have had cases where we've had someone have an ankle sprain. It was a young athlete, had an ankle sprain, presented with what could have been possibly an avulsion fracture. Get the x-ray, you see something similar to this. It's really tricky to distinguish. But the good thing about an avulsion fracture, if there is a good thing about one at the base of the fifth, is they heal really well. So we've talked about the proximal diaphysis being a high risk. If it's just pulled off the base of the fifth, the absolute tip as an avulsion fracture, they heal really well. Yeah. So in that case, it's like, do we really need to know if it's a fracture or not? If we just offload it and settle it, it's going to heal well anyway. Here we have another fifth metatarsal fracture. This is an acute proximal diaphyseal fifth metatarsal fracture known as a Jones fracture. It's young because we can see it's a fairly clean break. There's no sclerosis around it yet. All you see is that sort of black line shooting through the metatarsal. So this is the one where they've injured themselves and you're really considering a surgical opinion. Personally, I would refer for a surgical opinion in this scenario, because what you want to avoid is a non-union. And this is possibly a non-union in this image where we're seeing some sclerosis sort of on the inside of that fracture line and around it, and it hasn't quite sealed over. And if you look at the next one, it's even more obvious, where we've got that sort of the white thickening around the fracture line, but the fracture itself is still open. So we have a non-union in this situation. Now on this x-ray, with a different view, you could actually see, I don't have it here, you can see a bony lump, which shows that there's bone being laid down, but just not in the fracture site itself. And if we go back and we talked earlier about the lack of vascularity in this area, this is where the fracture has probably disrupted that one vessel that was going to supply that region, and that's why it's at risk of non-union. I've had a few people have these screw fixated. I've had a few that have had a nail put in. The whole nail versus screw, it's not a decision that people listening will have to make, it's in the surgeon's hands, but often the debate is that a screw is really stable, but that can potentially lead to a fracture where the screw finishes because all the bending will occur distal in one spot, whereas a nail will have a bit of bend. And I've had someone who had a screw and a nail have a non-union, and then they went back in and had a plate where they basically plated that fracture and held it together and almost put some compression in there, and then they returned to sport. And on imaging it was a non-union, but they were pain-free and able to get back to running.
Yeah, that you kind of answered my question. The non-unions, do they mostly become asymptomatic, or is there a few that like really have ongoing issues?
Ongoing issues typically. So I think the only reason why that non-union was able to get back to play was it had the plate holding it together.
Yeah.
So there was minimal movement and they were comfortable and they were keen to get back to sport. And interestingly, they got a scan again on their foot down the line for a different reason, and it had healed. Yeah. So they were playing with a non-union radiographically, but down the track it had healed, which is obviously a good sign.
Yeah, so no, one to really have in the back in your mind. Yeah.
Exactly, yeah. These are the ones that the navicular and the proximal diaphysis of the fifth metatarsal, people at home are probably sick of me saying it, but they're the ones that you need to be really mindful of because they're relatively common and they are high risk.
Yeah.
On the topic of navicular fractures, here's an MRI of a navicular fracture. And again, the great thing about MRI is that we can see, in this case, you don't want to see it, but we can see a split in the navicular. We can see that line where the arrows are pointing to, and where we see an asterisk, we're seeing some bony oedema in that navicular. So again, that would trigger an instant referral to a surgeon. Now we're getting towards the end of the images, so I'll put this one up here because it's a calcaneal fracture that doesn't show up on X-ray. Now this is a bit of an older case, so it was confirmed with bone scan, and that's the image on the right, and there might be some people who haven't seen a bone scan or won't see many of them. That's a bit of an older way of diagnosing this. The reality is, as I touched on earlier, calcaneal fractures actually heal really well and don't need surgery, they don't need non-weight bearing. We'll talk about how we treat these a bit later. So the need to get the bone scan or the MRI is really not, I would say, it's not really justified. You could simply diagnose it either based on X-ray, and if that was clear, on your clinical assessment. Yeah.
And I guess the X-ray gives the patient that peace of mind that there's nothing, serious, serious fracture or anything. So then it can give you and them the confidence to, we're just going to treat it clinically and...
Correct. Yeah, and at that point, it's eliminated some of those other possibilities. Yeah. Sometimes you might get an osteogonum, a little accessory bone. Oh, that's what it was. Yeah. Or there might be a big bony spur at the back of the calcaneus, or something else. It could be something nasty lurking. So the X-ray, if it's clear, okay, right, we know it's not all those other things. We're going to pursue our clinical diagnosis. Yeah, definitely. So in summary, consider common fracture sites of the foot and ankle. And their differential diagnoses. So learn what they are and also think about what could it also be, because I don't want people to listen to a 2-hour stress fracture presentation and then everyone that they see for next month has a stress fracture. Okay, you need to think about all the other possibilities that they may have. Be aware of the typical clinical presentation of fractures and differential diagnoses, and we might be talking about these again a bit later. Order imaging modalities rationally, so have a reason why you're ordering them and why you might not order more. Be aware of how fractures heal and how this may translate to radiographic appearance. And be on the lookout for signs of delayed union or non-union because that might trigger a referral to a surgeon, or it might mean that whatever you're doing to unload the fracture, it requires greater deloading to help them out.
Thanks, Dan. That was a really thorough clinical assessment imaging masterclass. Do you have any tips for physios, or we might have some podiatrists tuning in for trying to learn that, I guess, palpation? When you were learning, were you just grabbing family and friends' feet and just like playing around with them?
When I was learning, I actually say I probably learnt most of it on the job, and just making sure that everyone that presented with being a podiatrist, they're presenting with foot problems, right? So there's plenty of opportunities. But as a physio, you're going to be seeing patients with ankles, sore toes. So whenever you get your hands on feet, it's just a good chance to reorientate yourself to anatomy. So palpate the navicular tuberosity, run your finger up so you know you're on the navicular, come slightly forward, find the medial cuneiform, practice playing with joints of the feet. So it is just time. Finding muscles and tendons, it's, I normally try and help myself by getting them to contract, and then I can palpate a little bit more easily. And I guess where physios would have an advantage is they're familiar with hands, and hand and foot anatomy is not too dissimilar. Obviously hands are very agile, and I use them a lot when I talk, but feet and hands are quite similar. So you might have some learnings from the hand that you can apply to the foot.
And with the images, do you try and look at all of them and see it yourself before you read the report, or?
That's a good tip. So that's what you're taught to do, is you look at the image first before you look at the report, because things do get missed. We're not talking about ultrasound today because it doesn't really, some people do use it to diagnose fractures, but it's not commonly used. Ultrasound, I find, I'm going to digress slightly, is very much about operator skill, I think, more so than the other images. So sometimes I can look at an ultrasound and go, well, they've clearly seen a better version at their end. I'm going to trust them to a degree. It's almost like, I often use the analogy, it's like watching a video and they've paused it and sent you the paused picture, but they had the whole film to look at, or whole movie. X-ray, the rule is you generally look at all the different structures, count all your bones. Obviously you want to zone in on where your problem area is, but I'd look at adjacent tissue, because there might be that differential diagnosis that could be lurking that you don't want to put the blinkers on. Compare left and right, just practice.
Amazing.
Thank you.
Thanks everyone for listening. We'll be back shortly with management. Welcome back everyone. We're here with Dr. Dan Bonanno talking about foot injuries, particularly stress fractures. So we've talked about some anatomy, physiology, assessment. We're going to talk about some management now.
Yes, this is the important part probably from our patient's perspective, is to obviously manage the fracture and get them back running. I'd say the first thing that most runners will ask is, irrespective of the diagnosis, when can I get back running? So we'll talk about some general principles of fracture management, and I've just dotted down some key points here that I would always come back to. And the first one is let the fracture heal. So that has to be priority number one, because if it doesn't heal, then they're not running again. So we need to get that fracture healed, need to reduce bone load as best we can, so that we can, I guess, increase the risk of them having a successful return to running. There was obviously a reason why that fracture occurred and why it occurred in that bone. So can we reduce load to that bone in particular? Can we increase bone capacity? So a lot of this would revert back to diet, sleep, recovery, and ties in with the next point, I guess, which is load management. So by incrementally loading our running programs, can that bone respond and get stronger and more adapted to running? And the last point is that once they're ready to go back to running, it needs to be a graduated return to running, and we'll go through a suggested running program on how we can achieve that.
Awesome, sounds good.
Okay, so most of this section is actually targeted towards low risk stress fractures. So we've got a couple of slides on high risk just to get it out the way, because most of the fractures that we'll be dealing with as a physio or podiatrist or whoever else is tuning in will most likely be low risk fractures. The high risks are more likely to be in a cam boot for a set period of time. I guess the return to running would be relevant to that group, or they might be referred off to surgery. So I guess the way that we'd handle a high-risk fracture is immediate immobilisation and non-weight bearing. And cam walkers are regularly used now. There was a time when most people would be put in a cast, but cam boots are quite good as long as you can trust the person will wear them. I've actually seen cam boots cast on so that I get removed, but that's normally not needed. And here we have a pneumatic cast that you can pump up. So you put the cam walker on and you can pump it up to get really good compression and immobilise the area as best you can. The other one to consider is early surgical opinion for two fractures in particular, two that we've talked about a bit today, navicular stress fractures and the proximal diaphysis stress fracture of the fifth metatarsal. Might just go back a point. So if you're putting someone in a cam walker, there would be the recommendation that they also would be on crutches. And then as they wean off that cam boot, they would remove the crutches and gradually return back to activity. But for most of the high-risk fractures, crutches, but not necessarily all of them. So the exceptions would be a base of second metatarsal fracture. That's in the high-risk group, but it's relatively stable. It's surrounded by 2 other metatarsals and the cuneiforms. So that's quite stable. A cam boot would be adequate for that. A cam boot would also be adequate for most sesamoid stress fractures. Some sesamoid stress fractures, a simple clean break and it's quite stable. Some can be in quite a few pieces, so that may not be true for all of them, but a cam boot works quite well for those high-risk fractures without crutches. Crutches for base of fifth metatarsal and navicular.
Yep, makes sense.
In regards to referring for surgery, what may happen if that were to take place is, particularly for the navicular and the fifth metatarsal, if interventions were required, they will possibly be fixated with either a screw or a nail, which we touched on earlier, or possibly a plate. Sometimes a bone graft might be put in there as well to try and stimulate repair. I've seen these procedures where a bit of hip bone's been removed and plugged into the hole to try and encourage regeneration as well. And
so typically, how long are we using our bony healing of the lower limb in general for the immobilisation period? Yeah, so the immobilisation's probably 8 weeks thereabouts. So it's not necessarily that much longer than what it used to be for a low-risk stress fracture. And even with surgery, you're looking at a similar time frame. So I read recently that the average return to sport after surgical intervention for a fifth metatarsal fracture was around 10 to 12 weeks, which is not horrendous when I guess that's a good outcome, but with a low risk bone stress fracture, you're probably still looking at 6 to 8 weeks anyway. Yeah. Yeah, and obviously give and take on the individual and all their other risk factors and history.
And I guess the decision that the clinician, the runner need to make is how much risk do they want to put into that return to running? Like how graduated do they want to return to activity? You use that marathon analogy, Olympic Games, you want to be back. If it's just getting back to running with family and friends, you might be inclined to go a bit slower.
Yeah.
Now we'll move on to low-risk stress fractures, and historically these have been managed with 6 to 8 weeks of weight-bearing rest. And a cam boot would be used if pain was present, but typically not necessary. So we're going to show some padding options that I've used over the years to try and deload particular fracture sites that can be easily implemented in clinic. But we've sort of moved away from this being inactive for 6 to 8 weeks. What's happened is there's a bit of a shift towards getting people back being active a bit earlier. And the reason being is if you're without running for 6 to 8 weeks, we get some changes which aren't desirable. So we get some disuse atrophy. So you might get some osteopenia, so loss of bone stock. That increases the risk of your next fracture if you're returning to running without great bone stock. We're likely to have reduced strength, reduced mobility. We're going to have a reduction in cardiovascular fitness, and in load management, there's a bit of a language that talks about the load floor and ceiling, and the floor is kind of where you're at, but if you're not exercising, it just keeps dropping, and your ceiling probably hasn't changed. If that's to run a marathon in a certain time point, what do you need to do? You don't want that gap to get too big because the return to running is going to be more difficult. So that model works in terms of fractures healing, but it sets up the runner for an unsuccessful return to running. It might be a bit longer, and I would feel that some of those changes put the runner at risk of a repeat fracture.
Yeah. And when you say until pain gone, is that on walking?
Correct, yeah. So the first sign of pain being absent will be just with daily living. So that is almost the first hurdle to clear, and we'll get to that now actually. That's a good segue to the optimal loading approach, which is used to guide a return to activity for low-risk stress fractures. And the initial aim, as it says there, is to reduce pain. So patient comes in, you've diagnosed them as having a low-risk bone stress fracture. The first goal is to get their pain down. If pain is present, it's suggestive that there is still stress on the fracture site, which we're trying to avoid. So ideally, they would just be weight-bearing rest, and they're comfortable. If that's not working for them, then we can add some padding to their shoes, which we'll go through some samples in a moment. If that's not working, you can put them in a cam boot, even on crutches for a short period of time, but you're wanting to get them back to weight bearing rest, i.e. living a normal life without the running, as soon as possible.
Yeah. And if they're doing something, they're on their feet for work and stuff, what's your advice there?
Well, that can be really challenging. Yeah. So in that instance, it's probably about weighing up how much stress is happening at the workplace. So if I'll give an example of a nurse who might be on their feet on a ward. They might be weight bearing, they might not be running, but there's not much rest. So they might have to negotiate either time off work or some sort of change in role within their workplace. They basically can use pain as the guide on what is the appropriate level of loading.
Yeah.
So unfortunately, the original model, which was put someone in a cast for 8 weeks, it's really clean cut. It's a black and white rule. We'll see you in 8 weeks and then we'll get you running again. But the advantage of this optimal loading is that people can load earlier if they're able to, and pain is the guide.
Yeah.
So as a clinician, that is your guide too. If they're sore, they're doing too much. Now, obviously part of this is they've been diagnosed with a fracture, they need to temporarily discontinue running. And the term temporarily is purely that, because we want to get them back running when they're able to. And that's the sort of language that I would be using with the runner.
Keyword for runners.
Keyword is temporary, and it's going to allow you to run. And I think the 2 points below that are also important. The reason why we're having a temporary break from running is to allow that fracture to heal and minimise the risk of it progressing. I think a lot of people, including myself, when I get injured, I often fail to think about the progression. Like, I can tolerate this, but it can get worse, as opposed to it might get better. So with regards to fractures, if you keep running on them, they will typically get worse. I haven't seen too many get better. I gave you my example of my sesamoids. I was still resting it during the week and padding it up, and I was a bit uncomfortable. They healed eventually. You'll want to avoid pain. That is the ideal scenario.
Yeah.
Early on, analgesia can be used just to make the runner comfortable. There's no need in them being in pain unnecessarily, so I'd be using something that's paracetamol based to take the edge off the pain. But it's not to take the edge off the pain so they can go back to work and do more hours and to go back to running to numb the pain. It's not that at all. It's about just getting them comfortable, and then they're going off that when they can. What some people may go for are non-steroidal anti-inflammatory drugs, which I would say avoid, because inflammation is a key part of the healing process. And there is some preliminary data that would suggest that actually delays the quality of the fracture healing. So avoid anti-inflammatories, use paracetamol if you need to. If that's not cutting it, simple things like ice, whatever gets rid of the pain is the main thing. The good thing about most low risk stress fractures is the pain isn't there for very long. You can deload them quite easily. Okay, once we've got their pain managed and we've had that discussion with them that they need to stop running, we're going to try and manage your pain. Pain is the guide for return to activity. We need to consider, I think, biomechanical considerations. So why did that fracture occur in the first place? Now, clearly it's happened because there was too much load for that bone to tolerate, but why that bone? I'm looking for some answers on why that metatarsal or why that navicular may be the bone that has failed on this occasion. So we're going to go through some videos shortly to look at some of these scenarios, but ones that stand out to me are looking at structural alignment of the foot. So looking at metatarsal length and position. Is a metatarsal longer than its adjacent metatarsals? If so, going to propulsion, it's going to bear more weight than its peers. The position's important. I've already mentioned, don't want to talk about myself all session, but I've had those sesamoid fractures. Something that put me at risk of that was my first metatarsal is plantar flexed, so it takes a lot of load. And at the time I was playing football, I had a lot of stiffness through my midfoot. So we had ground pressure pushing up on those sesamoids, and I wasn't really getting much dorsiflexion. So I was getting driven into that stud, into the ground. So looking at length and position is important. I've already touched on joint range of motion, just on that that last section. So making sure that there is good mobility in joints proximal, distal and adjacent to the fracture site. We want joints to move. That's how we can absorb bending loads and stress. If they're stiff, those loads can get pushed into bone and shift into bone, and that's when we're getting bending moments that may lead to bone damage, and then of course that cycle of failure can come about. Foot posture is important, both resting but more importantly with running. So you can put someone up on a treadmill and watch them run. If they're weight bearing laterally and they've had a history of fifth metatarsal fractures, that's a concern for me. If they've got a second metatarsal fracture and you can see them pronating and you can see that first metatarsal being dorsiflexed out of the way and they're bearing load on that second, that's a concern for me. They may run beautifully fine. There might be nothing that you can visually see as being a problem. That's also okay. It's just that you need to observe what's happening with running, because plenty of people look pretty good standing. They might look good walking. They might even look pretty good running, but you might see something that suggests to you why that bone is under stress.
Yeah.
And then running technique. So there is no one ideal running technique. So I wouldn't try and convert anyone into a particular direction, but there are some factors to look at. One is looking at running step rate. So if we were to increase someone's running cadence, we can actually reduce pressure under their feet in terms of impact forces. So they can run at the same speed, but have less loading under their foot. Less load means less bone stress. That could be particularly useful for someone who's had ongoing and repetitive stress fractures. I often don't try and change someone's running gait unless I feel that we need to, and I normally go down this path if all the simple obvious treatments have been done and possibly failed, then we get like, can we change a running technique? So increasing step rate is one way to go. I've got some images to show you on that shortly. Strike pattern is important. Earlier on, we had the runner with the forefoot strike, and we talked how that might impact on that fifth metatarsal, the bending moments and so forth. So in that scenario, the forefoot strike did play into potentially a fifth metatarsal fracture. It may not though. So you need to just sort of take that into account. Looking at centre of pressure is really difficult using your eyes. Unfortunately, the only way to really measure this is through using pressure mapping insoles. And I've got some examples on what that looks like. And again, I wouldn't recommend that everyone needs this. By all means, they don't. But some of those trickier cases where you can't work out why that same metatarsal keeps failing, there might be a mechanical reason that you can't visualise yourself, and that's where plantar pressure measurement can be quite useful. Again, we'll go through a case study. And the last point is don't assess too early. So if they're experiencing pain walking, we don't want them on the treadmill running because we're trying to tell them not to exercise. So you can save some of these assessments for later down the track.
Yeah, no, I think that's a good overview of those things to keep in the back of your mind. But as you said, more often than not, it's the load issue and the activity, change in activity.
And I think that's the main thing. We're talking about a lot of other factors here. I'd almost say they're almost somewhat peripheral if you don't get the load management right.
Yeah.
So you could have a foot that's structurally ideal, not that there is such a thing.
Yeah.
Metatarsals all appear the right length. Nothing's plantar flexed, nothing's dorsiflexed. There's good range, good strength. Yeah. But if your loading is poor, it's too much too soon, then you're going to get a fracture, or you're at risk of one anyway.
Yeah.
Anatomy that becomes really important with regards to stress fractures is looking at the range of motion at the first metatarsal. So I'm keen to establish whether we have good range, because in a lot of runners we can experience hallux limitus, which means the athlete doesn't have the ability to drive through their big toe. And what we can find is people then propel through their lateral forefoot, predisposing themselves to overload in that area, which could lead to some of the conditions we've touched on, such as capsulitis, synovitis, but importantly, stress fracture. So range of motion is important in the chair. I also like to inspect metatarsal length. And one way that we can do this is by plantar flexing the digits. And you can palpate the first metatarsal quite easily. Second metatarsal in this case is quite a bit longer, which is not uncommon. Third metatarsal typically shorter, fourth and fifth again. So we get this parabola that we typically see. In some runners and some athletes, we'll find that one metatarsal is slightly longer than the adjacent metatarsals, and that can predispose it to extra loading when they're going through the propulsive phase of running. So establishing length of metatarsal is important because we want to see if we have a long or even potentially short metatarsal. If it's short, it can overload the adjacent bones. Something else I like to inspect with the forefoot is seeing if we have a metatarsal that might be plantar flexed. So if we have a metatarsal that's sitting lower than its adjacent metatarsals, it is going to be prone to greater ground reaction force and plantar pressure. So what I like to do is establish the position of the first metatarsal, grasp the second, and I basically compare my thumb height on my left and right hand, and I work my way across the forefoot and just see if one metatarsal is sitting lower than its adjacent metatarsals. In this case, they all seem relatively flat and level, so no concerns there. I also think it's important to look at range of motion at the base of the metatarsals, because if we lack mobility, then we're more likely to have increased bending loads through the metatarsals themselves. So I like to just get a global assessment of range of motion through the frontal plane, transverse plane, and sagittal plane. And the sagittal plane in this case is actually slightly limited. I then inspect the individual metatarsals and look at range of motion. Now, we have lots of running athletes that lack movement through the midfoot, or they lack range of motion. It doesn't overly alarm me, but in the presence of a stress fracture, if I find that in the injured site there's lack of movement, that gives me an indication that we might need to do some mobilisation through that part of the foot. When assessing for stress fractures, I like to assess range of motion through the midfoot. Naturally, the metatarsals will articulate with the cuneiforms, so if we lack range of motion through that area, we're more likely to get bending moments occurring through the metatarsals. So just to get a general impression of midfoot mobility, I'll stabilise the rear foot, grasp the forefoot, and I'll assess in the transverse plane, moving the foot side to side. Sagittal plane, dorsiflexion, plantar flexion. Here we have some restriction in movement, and in the frontal plane, inversion, eversion. I then like to assess the metatarsals individually. So I'll grasp the first metatarsal and I'm simply trying to dorsiflex and plantar flex against the medial cuneiform. The second metatarsal, same again. This articulates with the intermediate cuneiform. Third metatarsal, lateral cuneiform. Fourth metatarsal and fifth metatarsal articulate with the cuboid. Typically lots of range of motion in the lateral forefoot. If we find restriction in movement, it's typically through the three central metatarsals. And if I find there's restriction there, that may indicate that mobilisation may assist the athlete when they're returning to running.
Dan, just one question on that one. Is too much movement ever a bad thing?
I guess if you have too much movement, it's probably not going to be a bad thing for that joint itself, but it may be for the ones next to it. I.e., and I use that first metatarsal as an example. If it were to be dorsiflexed out of the way, it's then going to expose the second metatarsal to more load. Yeah. So as long as that joint is quite healthy and it's quite mobile, that's fine, but it might load up the adjacent tissue.
Yeah.
So here we're going to do some mobilisation, just an example of a technique. I'm sure everyone's got their own way of doing it. Here we just have the foot rested up on a towel to try and just get the forefoot off the ground so that we can push down that midfoot. The one thing to note is I would not be doing this in the presence of the fracture. I don't want to be mobilising the fracture itself. So I wouldn't only be mobilising if I was confident I could avoid the fracture site or that the fracture is actually quite stable.
In terms of knowing if the fracture is stable, like when, how do you know that?
So there's a bit of a school of thought that they're pretty stable after about 10 days of being pain-free. But I still would avoid bending around the fracture site. I'd be trying to steer clear of it, and it might be that you're not mobilising that particular metatarsal, but you might be doing the adjacent ones. It could be that you're mobilising proximally, maybe the subtalar joint or ankle joint. Or if you are going to mobilise that metatarsal itself, it might be that you're just a bit cautious to start with. Again, using pain as a guide. So your patient will report if it's painful or not. If it is, you back right off. So here we're doing some ankle mobilisation. Again, I'm sure people at home watching will have their own techniques, but here we're trying to mobilise the ankle to maximise dorsiflexion. I'd only be doing this if I felt someone had limited ankle joint dorsiflexion, or if I was concerned that there might be some anterior ankle impingement and possibly a navicular fracture. So what can happen is if an ankle is stiff, for want of a better word, when we dorsiflex, it can dorsiflex up and sort of hit into the anterior aspect of the talus. Sometimes by mobilising the ankle, it allows the talus to translate forward with dorsiflexion, and sometimes you can avoid that impingement. So if someone presented with pain in that area, and I wasn't really sure what was going on, but I cleared some of their symptoms with ankle mobilisation, that would give me some comfort that it's less likely to be the navicular stress fracture and probably just anterior impingement syndrome, because I've been able to improve mobilisation and range of motion, and by allowing that talus to move forward and up, we can get better dorsiflexion and avoid that impingement.
Yeah, excellent.
The other thing with having a lack of dorsiflexion that might be relevant with metatarsal fractures in particular is if you have an early heel lift with running, you're bearing more weight on that forefoot and you've got those bending moments occurring a little bit earlier and for longer. So there's another school of thought that by promoting ankle joint dorsiflexion, you can reduce stress on metatarsals.
Yep.
And again, just another way to mobilise the ankle, this time with the patient in prone.
So it's doing the same accessory movement as what you were doing before?
Yeah, exactly right. Just a variation in technique.
Yep.
I'll let the viewers at home work out which one they prefer.
No, very good.
So after we've looked at metatarsal length, position, range of motion, and the patient is now pain-free, I think it's time to watch them run, okay? Because that's how they got injured in the first instance, if they're a running athlete. And this is obviously the movement and the mechanics of what caused their problem in the first place. So here we have the runner running barefoot, and we have the clinician. Looks familiar, Brooke. Now, I mentioned earlier, one thing about being barefoot is you're more likely to adopt a forefoot strike when you're running. So although this video shows the runner barefoot, it's likely to have a slightly different cadence. It's likely, the runner's likely to have a different foot strike, potentially, not always, but things are likely to look different. I've also seen people run barefoot and they look fine. I don't see anything there that I think might be contributing to their problem. Once they put their shoes on, I start to realise it's either wearing shoes that's part of the problem or the shoes they're wearing is part of the problem. So the next assessment is really having them run in their shoes. Something that often happens when people get injured running is they buy a new pair of shoes, and they might bring those new shoes to the consultation. But those new shoes, although they're good to assess to look at suitability, I'd actually rather see the shoes that they were wearing when they got injured, because that'll tell you whether that played a part in whether they got injured or not. Here we have our runner. It just so happens that it's finished on that final frame there, and we can see that right foot slightly pronated as they're going into propulsion. Now, if the runner in this instance had a second metatarsal injury or maybe a sesamoid injury, it's fair to say that there's going to be increased loading on that medial part of the forefoot. So looking at different phases of the gait cycle is also important.
And from a physio perspective, I would be looking at that knee and hip as well, proximal chain, and how that might be contributing.
Yeah, excellent point. So proximal stability is a big one.
Yeah.
I guess whenever you're watching someone run, if you're seeing movement, it's, well, why are they moving that way?
Yeah.
Being a podiatrist, typically start from the foot and go up, but never neglect the importance of having good proximal stability, because, as you know, if you're getting internal rotation of the femur, that can bring the whole leg inwards, and it doesn't matter what you do at the foot, some things may not change if you can't control that proximal stability.
Or vice versa.
Yeah. And sometimes a bit of both.
Yeah.
And we don't have any video footage of it here, but sometimes you can get real value out of getting the patient to do a single-legged squat, stabilise the foot, maybe put an orthosis under it, a structured shoe, get them to squat again. They might look really good. Like, okay, well maybe the foot's playing a big part here. Sometimes it makes no difference because the proximal strength and control so poor that leg is internally rotating regardless of what you're doing at the foot. So you're not going to be successful treating the foot alone.
Yeah, and our next masterclass with Nat is going to be looking at all of those things, foot, knee, hip.
Better tune in then. I better tune in. We touched on strike pattern earlier. Now, something that's really picked up over the last decade is running retraining and changing someone's running technique. Now, prior to that, I guess a lot of runners just ran. And if you ran a certain way at 15, that's probably how you ran for the rest of your life. But what we're seeing now is people are changing their running patterns and they're quite coachable and they're looking for it a lot of the time. So here we have a systematic review that Laura Anderson completed, so physio from Geelong, and she looked at the benefits and risks of converting from a non-forefoot strike to a forefoot strike. And what the review found, lots of data, lots of studies were included, a fairly clear theme. If you convert yourself to a forefoot strike, you reduce loads at the knee, so and the hip and proximal structures. So that's really appealing for a lot of runners who are dealing with those injuries, but it comes at a cost. There's a shift in load and it tends to shift down to the foot, ankle, Achilles, calf. So if I'm seeing a runner and they're presenting to me with a foot fracture, I really want to know, have they converted, and if they're a forefoot striker, have they converted to that technique? And if they have, what's the reason? It might be they can't run otherwise because they might have a bad knee. I know plenty of people like that. And by doing that, there's a risk of foot injury. And on this occasion, they've got a foot injury perhaps. It doesn't mean you have to convert their technique. It might be that you just have to re-educate. We need to load you a bit more cautiously next time round, potentially. Because I guess being a podiatrist, I'm quite foot centric, but it needs to be, their foot injury needs to be considered in light of their other injuries. Their foot fracture will heal. If it's a low risk stress fracture, it will heal quite confidently. But if they're managing a degenerative knee, but they want to keep running, then maybe that forefoot strike is what they need. Yeah. Either way, you need to take it into account.
And do people do it change to forefoot for performance benefits, or is there any evidence around that? And what's your advice if they can run better doing that, but it's at a cost?
Yeah, look, that is definitely a main motivator for people to convert to a forefoot strike. And Laura's review looked at running economy, as you can see in the title, and we found no benefit in converting to a forefoot strike. So there's a bit of a myth's not the word, bit of a belief, I guess, that
the
by
evidence
converting,
isn't there.
Evidence isn't there to support it. And what has been done has shown either no change or a reduction in running economy. So you actually go backwards, which is not overly surprising because you're changing your technique. And whenever you change something that you've been doing for a long time, you're probably going to be less efficient at it at first. So maybe they get a bit of bounce back over time, but you don't get those performance gains early based on what the research tells us at this point.
And I'm assuming the studies might not have followed them for long enough.
Correct, no, relatively short term. So foot strike is an option, but we know it comes at a cost. If you convert to a forefoot strike, you're increasing load at the foot, and when we talk about foot fractures, that's not really what we're striving for. An alternative, if you want to reduce load under the foot, is to increase step rate. So this was a study that we did a few years ago, just measuring pressure under the foot we increased and decreased step rate. Not many people decrease step rate, so we'll focus on the increase in step rate. And what we found is by increasing cadence or step rate, we reduced pressure under the midfoot and heels of our runners, but we didn't increase pressure in the forefoot. Okay, so it's one way of actually globally reducing load and not shifting it anywhere. And then if we look at ground reaction force data from other studies, the same thing happens. There's actually less ground reaction force with an increased step rate. And then we look at what's happening between the insole and the the insole and the foot, the same thing. It's not translating in any increases in load under the foot. And if you're interested in running retraining, a little plug to Laura. She has another systematic review coming out soon around step rate and its effect on load at the foot, calf, leg, and so forth.
And I'm assuming that would explain some of the biomechanical reasons why that's the case? Shorter, faster steps,
Exactly,
going at the
yeah.
same speed. Yeah.
Same speed, so shorter, faster steps, less vertical oscillation typically, less extension of the hip, less flexion of the hip.
Yeah.
Almost everything just drops because you're taking shorter strides.
Yeah.
Running economy, again, I won't spill the beans just yet, but often when you change things, it comes at a cost.
Yeah.
But when we think about stress fractures of the foot, it's a change you can make where you can reduce load running at the same speed,
Yeah.
which is not normally what happens. And if you run at the same speed, you don't change load. You normally have to run slower to change loading of the foot.
Yeah.
In this case, you can achieve it through increasing step rate.
Yeah. And your foot's obviously landing underneath you a little bit more than like.
Yeah, exactly
front.
right.
Yeah.
So thanks for that. That's a good point. So if you're running with a longer stride, you're typically reaching out in front and you've got more of a heel strike. Now you might still remain a heel striker, but it might not be at the same angle.
Yeah.
You may have a slight, they call this a strike index, where you're landing on your foot. You might have a slight heel strike, and by increasing cadence, it might become a midfoot striker, or midfoot becomes slight forefoot. Either way, you tend to have a slightly more distal strike index.
Yeah. I think that visual is good for patients to show them.
The
why
angles,
to try and get them to buy into it. Yeah.
Yeah, and the cue that you've just talked about, shorter, faster steps, I find that's a good one to use.
Yeah.
It's easy to understand.
Yeah.
Most easily done on a treadmill, because shorter, faster steps sometimes means running faster for some people.
Yeah,
It's
you
hard to
can
control
control
speed. The treadmill's a good place to start.
Yeah.